My name is Fatimah, and this is Tom. Together, we are proposing a study to examine palliative care techniques to improve outcomes for glioblastoma patients and their families.
Glioblastoma is considered the most common aggressive type of brain tumor. As you can see from the prognosis, it is fast progressing, which makes palliative care very important.
Glioblastoma is a condition that introduces a series of challenging symptoms over a very short period of time. Like Jacques, the 56-year-old accountant in our case study, glioblastoma can begin with forgetfulness and weakness and later progress to dysphagia, headaches, cognitive impairments, and adverse effects from medications. These symptoms result in functional impairments such as the inability to fulfill family and work roles. This can in turn contribute to severe impairments of an individual's quality of life. Currently, a multidisciplinary approach involving neurosurgeons, neuropathologists, oncologists, and radiologists is currently taken to treat glioblastoma. While the current approach reflects advancements in our knowledge on how to best treat glioblastoma, this approach could better incorporate ways for patients and their families to prepare for the changes in quality of life associated with this brain tumor.
We believe our study will identify the palliative care strategies that will best support quality of life in glioblastoma patients and help standardize palliative care for these patients.
There are several misconceptions about palliative care. Palliative care is not simply managing pain at the end of an individual's life. Palliative care is a multidimensional approach to caring for individuals with life-limiting illnesses that focuses on their mental, physical, and spiritual needs.
The three interventions are COMPLETE, Dignity Therapy, and the COMFORT curriculum. The first intervention, COMPLETE, stands for Communication Plan, Early Through End of Life. Most of the research on it has involved children with brain tumors and has thus been directed at parents. However, it won't be difficult to adapt the intervention to any patient and caregiver. It is based on these two theories, which examine distress and coping responses and together guide the creation of COMPLETE, which focuses on how clear and timely communication can foster positive coping and reduce distress. COMPLETE has been shown to increase receptiveness to the idea of palliative care, decrease decision regret and uncertainty, and to increase hope.
The second intervention that we will be implementing is dignity therapy. Dignity therapy is a brief individualized psychotherapy session for individuals with life-limiting illnesses. This therapy is designed to target psycho-emotional and existential distress to improve the patient experience. It creates time for patients to reflect on what's important to them and what they would recall and like to share with others. An example would be question 2, where patients are asked if there are specific things they would want their families to know and remember about them. This therapy has been shown to improve end-of-life experiences by decreasing depression, anxiety, and improving existential and psychosocial distress.
The last palliative care intervention is COMFORT, which stands for Communication, Orientation and Opportunity, Mindful Presence, Family, Openings, Relating, and Team. COMFORT was designed by considering empirical research in all aspects of communication, communication within the healthcare team, family communication at end of life, and discourse between the palliative care staff and the patient and family. Unlike Dignity, COMFORT does not follow a defined algorithm and should instead be considered a set of holistic principles. Nurses concluded that COMFORT improved communication in multiple contexts, between them and the physicians, nurses and patients, and it helped remove structural barriers between nurses.
Our proposed study design is a randomized controlled trial composed of patients recently diagnosed with glioblastoma. The patients will then be divided into the 3 therapies that we just explained and a control group that will receive the standard palliative care by their healthcare facility. The efficacy of these techniques will be measured using a comprehensive survey that we will create, and it will be administered to both patients and their families. The survey will measure communication satisfaction, uncertainty about the future, understanding of prognosis, mood, and other aspects. The patient and family will then be surveyed every 6 weeks.
We believe this will identify the most effective palliative care intervention. Because these interventions are not mutually exclusive, we believe the most effective components can be identified and potentially combined in future research. For example, there's no reason dignity therapy couldn't be used alongside the comfort curriculum, and it's likely that both together would lead to even better outcomes. Finally, we believe this will lead to improved confidence and communication among healthcare teams.
Thank you for listening to our research proposal, and we really would like to thank the Brain Tumor Foundation of Canada for this opportunity. Thank you.